Welcome to 39 Essex's webinar, which is aiming to provide you with a rapid response to the long-awaited changes to health and social care, which were announced this week. At 39, we've got a big team of barristers with a huge range of experience in the health and social care field, both in terms of service provision, funding, and challenging from the perspective of individuals and other institutions. And we've got a few of us here today to give you our immediate thoughts, as well as some of the headlines, and perhaps spare you reading all the lengthy documentation. Doubtless there'll be a more considered response in due course, but we think it's helpful to have a look at these things fresh from the government today. The way in which we're going to organise things is that Arianna Kelly is going to speak first, particularly about the cap on care costs, means testing, and the new proposed duties to self-funders. Arianna and I are involved in quite a big case at the moment already about the way in which social care charges are being implemented. And so I know that she's got a real interest, experience and commitment in this area. After that, Sian Davies is going to talk about market shaping, the risks of provider failure, and perhaps some of the challenges that may come from the new arrangements in relation to that. In terms of how we're going to organise ourselves and also hopefully make this webinar as interactive as possible, what we hope is that if you have questions, you'll type them into the Q&A box. And after Arianna's spoken, which will be for the first sort of 20 minutes or so, I'm going to try and pick up some of the best ones and ask Arianna to deal with those coming out of her talk, then pass on to Sian, and then hopefully leave a substantial amount of time at the end for more questions and discussion, because of course, there's a huge amount to think about and a great deal of uncertainty. And what I will do is that we make sure that we finish just before 6 o'clock, because I'm sure you've all got lots of other even more interesting things to do than think about these new arrangements. So what I'm going to do now is briefly disappear and hand over to Arianna.
Thank you so much. So we're starting just with a discussion around what's in the command paper, which has been issued on the 7th of September. There is a white paper and further regulations would be expected, setting out more of the granular detail of how the cap on care costs and the features are going to work. But the command paper does give quite a bit of useful information to see a roadmap of where this will all be going. And very helpfully, it notes that this framework will be following the cap on care costs, which was set out in the Care Act 2014. For those of you who were involved in it in 2015, there was obviously quite a bit of work that was already done to progress it, with the view to having it first being implemented in 2016, then delayed till 2017, and then delayed on an indefinite basis. But I would just give a general health warning that the command paper is certainly at a very high level of generality, and that further documents will be needed to define precisely how this will work. So just starting with what's already in the Care Act and what we already know to date, Section 14 of the Care Act creates a power to charge for care and support. This power is limited by the cap on care costs in Section 15, which is yet to come into effect. And a local authority is not allowed to charge for the care of a person who has exceeded the cap on care costs. It was a little unclear in 2015 the extent to which this was in relation to both income and capital, but the command paper does set out that it is going to be in both relation to income and capital, and people who have exceeded the cap on care costs will not be charged at all for their care and support. Section 15 establishes the cap on care costs, and again, what it states is that a local authority may not make a charge under Section 14 for meeting an adult's needs under Section 18 of the Care Act if the total costs accrued in meeting the adult's eligible needs after the commencement of care costs exceeds the cap on care costs. Now, it's not clear to the extent to which this would apply to the Section 19 power of a local authority to meet needs on a discretionary basis if a local authority is doing that. It's only limiting the power to charge in relation to Section 18, and the local authority can make a charge under Section 19 if it's choosing to meet needs. However, this is probably going to be relatively limited cases, and I imagine there probably will be further information on this in guidance and regulation as to how that could be used in the event that it's discretionary meeting of needs. Unpacking what's in Section 15, there are a couple of really key limitations in terms of what the extent of the cap of care costs measured. The first, probably most important one, is that the costs accrued in meeting eligible needs are the only ones which go towards the person meeting the cap on care costs. So this is eligible needs only. Costs in meeting needs that are not eligible for support under the CARE Act do not count towards that cap. And if those of you who are involved in administering these sorts of things know, the eligibility test is not necessarily always an easy one. It has to be being unable to meet two outcomes. And as a result of that, it causes a significant impact on the person's well-being. So you would need to get to the stage of making a formal eligibility determination to determine what of a person's needs would go towards the care cap. It also relates to costs accrued in meeting eligible needs after the commencement of the section. So this is not a retrospective provision. It won't matter how much a person has spent on meeting the cost of their care needs prior to October 2023, and would only be looking at costs accrued after that date. Another big limitation in Section 15 is that if the person's needs for care and support are being met by the carer, the putative cost of meeting those needs for the local authority would not count towards the cap on care costs. This also relates to the Section 18 duty overall to a person, because there is no Section 18 duty which arises insofar as a person's needs are being met by a carer, even if those needs would be eligible under the CARE Act. And again, carer, very much a term of art within the CARE Act, referring to unpaid rather than paid care. Now, the real question on this, and one which I think is going to cause an enormous amount of work in the actual administration of the cap, is how do you know what the cost is of meeting a person's eligible needs? Because certainly for many self-funders, they will be interacting with the local authority very little or not at all, and will simply have gone away and made their own care arrangements. In order to get a running cap going, a self-funder will need to have a needs assessment. There will need to be a formal eligibility determination made. A care plan will need to be written to determine what care is required to meet that person's eligible needs for care and support. And either a personal budget or an independent personal budget will need to be written. A personal budget tracking out the cost to the local authority of meeting the person's needs if the local authority is doing it, and an independent personal budget if someone other than a local authority is meeting the person's needs, usually themselves or someone making arrangements on their behalf. And it's this independent personal budget, which would be the really interesting thing, because this is something that was set up within the CARE Act in order to administer the cap on care costs, but really hasn't come into effect right as yet because the cap on care costs hasn't been brought to life. The question of an independent personal budget is not how much the person is spending in meeting their own needs for care and support. The relevant cost for an independent personal budget is what the cost would be to the local authority of meeting the adult's eligible needs for care and support itself. Now, this ties in with another really interesting thing introduced in the command paper, which is a new provision which is likely to be introduced, and it's going to need a lot more detail about all self-funders being able to have a local authority meet their needs for care and support, rather than the subset that currently are entitled to have that happen right now. But if you're looking at this, if you have a person, say, paying for a care home, the question would be first, do they need it? Would they get it as an eligible right under the CARE Act? Would their care plan involve that care home or maybe a different care home that wasn't as expensive? And how much would the local authority have actually paid for that? So that's a number that may have relatively little connection with the actual out-of-pocket costs that the person is experiencing on a month-to-month basis. There's also a lot of administration for local authorities in keeping track of these over time. Now, a local authority is required to maintain a care account for each person, and it has to contain all of the person's spending on care. Again, certainly need to get more in terms of detail and guidance and regulation as to whether or not this is including income as well. But there isn't any specific limitation as yet implying that it would not be in relation to income. So this may be people who are paying charges throughout their lives. It has to be maintained throughout the person's life or for 99 years from the day that the person last paid out of pocket for care. The cap also will be adjusted on an annual basis, assuming the Section 16 provisions currently in place remain in place. This would require the Secretary of State to adjust the cap upwards on an annual basis in accordance with the average earnings in England and in the UK, and how much they had gone up on an annual basis. In order to maintain the person's progress towards the cap, the accrued amount under the cap would also rise by that same percentage on an annual basis. So local authorities would have to check this amount on an annual basis and make sure that they were keeping it updated to track the progress with the care accounts as well. Another big limitation on the cap of care costs is around daily living costs. There is in the Care Act quite a lot of infrastructure right now to separate out the daily living costs of a person from the costs of meeting care needs specifically. And hearing some of the government discussion around this, is often emphasized that people will be incurring daily living costs wherever they were, even if they were living outside of a care setting. So hotel costs, food costs, heating, and that sort of expenditure. Now, clearly for people in their own homes or people who have their own tenancies, for example, in supported living accommodations, these may be much easier to separate out because there's a clearly defined cost that the person is paying for housing. However, care home residents have usually been the problem because you do have the unity of provision between care and accommodation for people in those settings. And there has to be some mechanism to take out the daily living costs from essentially a bottom line figure. These would also remain chargeable after a person has exceeded the cap. So a person may still need to contribute to care home fees even after they have met the cap by paying the £86,000. This was an issue in 2015 where there was quite a bit of discussion, particularly in the north of England, around how this would affect people in different areas, because obviously different care homes in different parts of the country cost very different amount. There had been a suggestion that this would be a flat rate of £230 a week in order to try to, a flat rate of £230 a week in order to try to make this a more straightforward calculation rather than individualized determination in each case. However, certainly in the North of England, there was a lot of concern that this would really slow down a person's progress towards the cap quite substantially and result in differentiation in which people could live for years and years in care home in some setting without meeting the cap. But in more expensive care homes, they would accrue towards the cap much faster. So again, certainly a space to watch in terms of how that will be considered. So what we know from the cap, from the command paper so far, is that the cap will be coming in from October 2023, and there is no suggestion of a retrospective application. The amount is to be £86,000. There isn't anything specifically mentioned around the adjustments annually, but the paper does confirm that it's within the Care Act framework, which contains that provision for the annual adjustments. One of the interesting points that's not in the Care Act, but is in the command paper, is that it references the cap on care costs being towards costs spent on personal care rather than eligible needs. The Care Act framework was always around eligible needs, which would be the full plethora of a person's needs rather than those solely relating to personal care. Interestingly, if this was around personal care, that would start to bring something of an alignment towards the Scottish system where all personal care is free. But this would again be a space to watch, certainly in terms of seeing how personal care is actually defined, and if that's defined in the same way as it would be by the CQC in terms of it being the registered activity of personal care, because that would be very much a subset of a person's eligible needs. The command paper also specifies that income charges would end once the cap is met, and top-ups would not be included in the accrued amount towards the cap. Now, I've just included, for the sake of interest, in 2015, there was quite a bit of work that was done around this, and there was a consultation on draft regulations, which went out specifically considering how the cap would work. One of the points that was made, and this is an interesting point that will certainly need to be grappled with further, is the difficulties of pricing out how much a local authority would have spent to look after the person had it been asked to do so. The consultation on the draft regulations also noted that the cost of a care home bed can depend on any number of factors, such as the availability of beds on the particular day or block contracts that might apply. So you could get people who are very much similarly situated, but one of them is able to get a bed for a different price than another person. And that would not necessarily have the same personal budget as between them. The consultation on draft regulations also suggested that the fairest approach would be for local authorities to set independent personal budgets by taking an average of the personal budgets the authority had given in the area to people with similar levels of needs. Now, one of the interesting things about this as well is this is again potentially a regional issue to be looked at, because local authorities where you have lots of people on block contracts rather than lots of self-funders may potentially end up in a situation where the average cost of a bed is much lower in certain regions. You've also got wealthier and less wealthy regions of the country. So again, you could have similarly situated self-funders in similar areas who are getting fundamentally different costs meeting their care, but have the same independent personal budget. Again, all of this is going to be very much up for discussion and consideration as to the mechanics of how this is going to work. And there's 2 years before the implementation. But I think it is to say the mechanics of this are incredibly important, because the way that a person progresses towards the cap is not necessarily going to be the same depending on where you are. Now, another point that may be of interest, and again, certainly I imagine will merit further discussion, the Dillon Commission had recommended much lower lifetime cap. They had recommended 25,000 to 50,000 pounds per person, also an increase in the upper threshold for capital eligibility. But notably in the Dillon Commission, they had recommended free care for people who turn 18 with care and support needs, or who develop them before the age of 40, and then a graded system for people who develop needs after the age of 40. This was basically working from the assumption that people who are older could anticipate that they may come to have needs for care and support. However, younger people couldn't necessarily be expected to plan. And certainly for some people who had never been able to work, they wouldn't have necessarily been able to accrue any savings. There's a specific provision within Section 15 of the CARE Act that allows for regulations to be made to set a nil cap for people of different ages or different descriptions. And in February 2013, the plan had been to have a nil cap for people who turn 18 with care and support needs. So this is very much, again, a watch this space in terms of how this will all play out, because there's already statutory provision within the CARE Act to allow for a nil cap for younger people. And that had been the intention when this was being looked at, now admittedly 8 years ago and in different circumstances and et cetera, et cetera. But there is a mechanism for it already within the CARE Act, and it was a specific Dillon Commission recommendation. So I think it will certainly be one that will attract further attention and likely be addressed. One of the other big changes that was made was changing the means testing for care and support. So the command paper sets out that there will be new upper and lower capital limits of respectively 100,000 and 20,000 pounds. The current upper and lower capital limits being 23,250 pounds and 14,250 pounds. The command paper confirms that the current rules for where a person's main or only home would be disregarded for the purposes of determining accessible capital would remain in effect. So this was again an issue that had attracted a lot of attention in 2017, and particularly in the election, where there were discussions around social care reform, but with a suggestion that people's houses would not necessarily be disregarded. This plan is quite clear. The disregard for the main or only house would remain as it is now. So under the new rules, only people with 100,000 pounds or more in accessible capital would be responsible for paying the full cost of their care. And people with less than 20,000 pounds would not be required to make any contribution from their capital, but would still have to pay an income charge unless they had already exceeded the cap on care costs. Now, individuals with accessible capital in between 20,000 and 100,000 pounds would be required to pay a tariff income. It appears to be broadly aligned with the current rules, and a person would be required to pay not more than 20% of their chargeable capital annually, though it's not clear whether the last 20,000 pounds of a person's capital would be considered part of that chargeable capital. And people would also continue to pay any relevant charge on income in addition to the tariff income they were paying, unless they had already exceeded the cap on care costs. So this is, again, one of the issues that I'm surprised hasn't attracted more attention, because I do think this will be a really important one in the context of the care market. And I know Sean's going to go into much further discussion as to what the impact might be. I put on the screen a quote from the command paper itself, which is not explicit as to how this is all going to operate, but gives something of a direction of travel as to where the government's looking at taking this. It says, we will also tackle persistent unfairness in the social care system. Under the current system, people who fund their own care often pay more than people who are funded through the local authority for equivalent care. For the first time, using legislation in the 2014 CARE Act, we will ensure that self-funders are able to ask their local authority to arrange their care for them so that they can find better value. Now, one of the interesting things is many self-funders can already ask people to provide their care for them now. Under Section 18 of the CARE Act, if any self-funder who is living in their house can ask the local authority to arrange their care for them pursuant to an arrangement fee. Any self-funder who lacks capacity to make their own care arrangements and either doesn't have someone appointed under the Mental Capacity Act or someone otherwise in a position to do so, can ask the local authority to make their care arrangements regardless of the location in which they're receiving care. It's only capacitous self-funders or living in care homes or people who lack capacity but have someone designated under the Mental Capacity Act who are not allowed to ask the local authority to make their care arrangements. What's notable about this is not so much around the local authority making care arrangements for the person, it's around the suggestion that they would be able to access the same rate that the local authority would be paying for care. Because certainly in my own experience, and I'm sure there's differentiation between local authorities, but I've seen very few local authorities that provide care for self-funders on local authority rates. And in fact, many local authority rates, including in the Torbay case, relied on the fact that there would be other participants in the care system who would be paying more than the local authority to sustain the market. So this is, again, very much a watch this space and see how the detail on this goes on to develop, because this seems like it could be a fairly significant change in terms of the duties to self-funders and the rates that self-funders are able to access. In relation to income charges, the freeze on the personal expenses allowance and minimum income guarantee is to end. And from April 2022, they're both going to rise in line with inflation. We've also gotten some suggestion from the command paper that there will be a change around deferred payment agreements. It confirms that deferred payment agreements are to remain as they are, but DHSC will work with partners to review the existing scheme in order to provide more flexibility for people to defer their care payments. But I'm not quite sure exactly how that's going to work. So that's my whistle-stop tour through the changes to social care funding. And now I think we've had a few questions which we are going to go to.
Yes, Ariana, thank you very much. That was really fantastically helpful for the headlines and some considerations flowing from them. Just to reassure anyone who's been at all overwhelmed by the volume of information, that we'll be sending out a paper to anyone who's attended, which will give them that material in a way that they can review at their leisure, if that's their idea of leisure. In terms of questions, I think there are 3 that I'm going to pick up if I can. First of all, I think there seems to be a lot of uncertainty about what will and won't be counted into the cap. And so people have been saying, well, will it include respite care, night care? I mean, what do you think might go in, what might come out? What don't we know about?
So if they're following the framework under the CARE Act, it's all eligible needs. So to the extent that, I mean, so certainly from respite care, I mean, respite care is care to the person. So that would typically fall within an eligible need insofar as it's being delivered for, because there is no care available to look after the person at that point in time. Night care, I think it's difficult because, again, with many local authorities, night care is not always necessarily provided, and sometimes that is regarded within income charging as to whether or not there should be exemptions around night care. But it would be anything that the local authority would have considered to be an eligible need for the person is the CARE Act framework. I think the real question from my perspective in terms of looking at the command paper is whether this is going to be limited to personal care or whether it's going to be eligible care, but that remains the current statutory framework.
And then another question flows from this idea about self-funders asking the local authority to do some arranging. Do you think that local authorities are going to be charging an admin fee? Do you think they'll be allowed to do that?
So, again, since 2015, self-funders who wish for the local authority to make arrangements for their care can be charged an arrangement fee. I've often seen that in a way that there's often a designated person or persons within local authorities who look after the self-funders, and those costs are shared proportionately among the self-funders. There is no power to make an arrangement fee if a local authority is doing it under Section 19 of the CARE Act and they're doing it on a discretionary basis. So if for whatever reason, the local authority has decided to meet the needs of a person it's not obliged to meet the needs for. So, for example, a person who had a lasting power of attorney or a deputy able to make the arrangements but wanted the local authority to do it anyway, they couldn't do that if they weren't obliged to do it. So I would expect the local authority to be using their arrangement fees, particularly if there are going to be many more self-funders approaching them in order to make those arrangements for them in order to access the block contract rates.
Now, I've got one more question on a topic which I know is dear to your and my heart, which is how does all this work with the Norfolk case? And we've got another case following on from that. And we're being asked, do we think the government will take into account that decision when looking at working age adults and what income they have to contribute? Or do you think that's just going to be hived off to a separate question?
Well, I think one of the really interesting things on this will be the extent to which the government proceeds on its plans from 2013 to look at a nil rate for for people over 18. Because if they do pick that up, there would be no charges for anybody turning 18 with care needs, which would be, I mean, I have no idea of the numbers, but I mean, it would certainly be quite a lot of the people between 18 and 64 who are currently subject to income charges. If they were already considered to have a nil rate for cap on care costs, that would preclude any income charges from happening for those people at all. So, I mean, that would certainly be a very interesting interplay with the Norfolk judgment if we had a new care system in which no one between 18 and 64 who had care needs that emerged at a younger age was charged at all. So I think probably the best I can say is watch this space, but I think there is certainly very much an interrelationship between the two insofar as the cap on care costs would impact on the ability of anyone of a younger age to be charged an income charge at all.
Oh, well, thank you very much. Now, I know that we've got a lot of other questions, but I'm also keen that we hear from Sian, and we built in some more time for questions at the end. So if you keep your questions coming, and if we hadn't answered it yet, hopefully we'll do that in the last section. And I'm going to disappear again now and hand over to Sian.
Thank you very much. I hope that I've managed to share my screen. I think I have. So I'm just going to talk a little bit about sort of one aspect of the proposals in the command paper, and that's the sort of the impact on market shaping and the provider failure provisions of the Care Act. And just for a sort of brief refresh, if you need it, the relevant bits of information are, there's a link to the command paper, and then the particular sort of bits of the care and support statutory guidance that relate to this are chapter 4 and chapter 5. So chapter 4 on market shaping and chapter 5 on provider failure. So market shaping, it comes from section 5 of the Care Act, and it requires there to be effectively a strategic approach to the market for care provision in the area of a local authority. And we get the core duty in relation to that from section 5, subsection 1, which is to promote the efficient and effective operation of a market in services for meeting care and support needs. And then there are a number of factors set out in section 5(2) to 3 that the local authority must have regard to. So obviously those aren't outcome related duties, but sort of procedural and decision making factors that need to be taken into account. And then at section 5(4) we get the sort of relationship to the wellbeing principle, which is obviously the sort of overriding principle of the Care Act. Commissioning is dealt with in the guidance, the care and support statutory guidance. And I've just picked out a couple of quotes from the guidance. It talks about promoting diversity and quality within the market by reason of commissioning activity. It talks about local authorities creating a vibrant, responsive market. And it should do those things by understanding the market and by commissioning and facilitating interventions. So that's what the statutory guidance is telling local authorities to do. There is also a joint health and wellbeing strategy, which, according to the guidance, at 4.52 should contain an assessment of local needs. So that's the sort of the policy or the strategy by which local authorities are required to evaluate what they currently have in their area in terms of being able to meet needs, but also project into the future in terms of how those needs might change and how those changing needs might require to be met. And then the final sort of document that's referred to in the statutory guidance is something called a market position statement. And that's described by the guidance at 4.34 as a way of showing that the Section 5 duty, so that's the sort of the core market shaping duty, is being met. And the idea is that the market position statement should effectively conduct a sort of supply and demand analysis with that consideration of future needs and trends, and should include planning for anticipated needs. So in other words, that should be working to the future as well as the present. Obviously, the reality, as we've seen, has not always worked in the way that the guidance clearly hoped. That the thrust of the guidance is that what should be happening is that local authorities should be able to plan their needs and how those needs are going to be met in the future, that they should be making their commissioning decisions to create this vibrant, responsive market, and that the market should therefore be meeting the needs, with the market positioning strategy periodically being amended to reflect changes that are needed in that landscape. Obviously, it's very easy to sort of selectively find examples of where things have gone wrong, but there have been some high-profile examples of care homes, care providers failing. So that's where we get into the provider failure territory. And there are just two examples that I picked out from an admittedly very quick Google search, one from this year and one from 2019, as examples of chains of care providers unfortunately failing. Obviously, the consequences for residents in care homes are very serious when that happens. So now we come to the command paper, and it's interesting that Arianna and I both sort of picked out a key part of the command paper, I should say independently, that we thought was interesting and significant. So I'm supported in my view that it's significant by the fact that Arianna also thought so. What the command paper says is this: we will also tackle persistent unfairness in the social care system. Under the current system, people who fund their own care often pay more than people who are funded through their local authority for equivalent care. Well, that's the reality that we know of, that the self-funder may be in the same care home as the person who is placed there by a local authority pursuant to a duty to meet eligible needs. And the self-funder will often be paying a higher rate for what might be regarded as equivalent care, as compared to the person whose care is funded by the local authority. And that's because of obviously the market position of the local authority as a sort of bulk buyer of care provision, with the individual obviously not having that sort of purchasing power to negotiate a better rate. So the command paper goes on to say, for the first time using legislation included in the 2014 Care Act, we will ensure that self-funders are able to ask their local authority to arrange their care for them so that they can find better value care. Now, that doesn't really tell us very much about this, but obviously one of the possible outcomes of that part of the command paper is that there will be an end to the sometimes striking difference between the local authority rate and the self-funder rate for what might be regarded as effectively the same provision. And so the question that gives rise to is what impact on the market? Because the market in some areas it is propped up, certainly the market for local authority funded care, it is propped up by that differential between the rate that the local authority pays and the rate that the self-funder pays. And so I think one of the sort of core questions that comes out of this is how will the market be sustained if there is no longer that differential? Added to that, there are other impacts because, of course, all of the command paper proposals are intended to be funded by an increase in national insurance contributions. And some of those national insurance contributions are going to come from employers. So necessarily the care providers who form the market are going to have increased costs in the form of increased national insurance contributions. There are other factors affecting the market, such as Brexit having given rise to staff shortages. There are reports in some areas that vaccine requirements are giving rise to a shortage of trained care staff. And so all of those factors go together to indicate that the likely trend is going to be an increase in the cost of care provision. Local authorities are going to need to factor those impacts into their joint strategic needs assessment and their market position statement that those documents referred to in the care and support statutory guidance. And the risks of provider failure need to be identified. So the relevant law on that, section 48 to 57 of the Care Act, and then the provisions of the statutory guidance that are in the resources page linked to, and also the Care and Support Business Failure Regulations 2014. Those provisions aim to ensure that care and support needs of service users are met in the event of business failure. Business failure seems to me to be one of the real prospects that local authorities need to be factoring into their market shaping predictions, their supply and demand analysis, and also their predictions as to the cost of meeting needs into the future. And I can see potential scope for challenges to local authorities where they don't comply with those market shaping duties, where they haven't properly considered the impact of those separate and cumulative changes on the market, or where the rates that they pay for care at present don't allow for a sustainable model which going forward can meet the needs arising under this new model of care funding into the future. So I think what I'm going to say by way of conclusion really is that there is a lot for local authorities to take on board in terms of amending and altering and revising their market shaping, their market position statements, and looking at the question of what the financial consequences are going to be, both on the demand side in terms of individuals wanting to set up their individual budgets so that they can their costs can go towards the cap, but also on the supply side to ensure the market remains as the care and support statutory guidance says it should be, a vibrant market that can meet local needs. So I think that concludes everything I have to say about that. Thank you very much. And I think now we've got an opportunity to throw some more questions around.
Yes, thank you very much, Sian. Well, quite a lot of our attendees and myself as well have been really thinking about whether we might end up with some sort of perverse negative consequences for these proposals when one thinks about the impact on providers. So, for example, one can imagine a provider who does effectively cross-subsidise their service by charging more to self-funders. If they're going to be effectively compelled to provide to those self-funders at a lower rate, where's the money to keep their service going to come from? Then it's going to have to come from the local authority. And my impression is, and perhaps I haven't read things as thoroughly as you have, that this hasn't really been grappled with in the paper or by the government.
I think that's right. And I think what's really interesting is that the way this is being sort of billed politically is an injection of cash for social care. And actually, it doesn't take too much drilling down, even at the stage we're at now, where we've only got this command paper to go on, to see the potential for this actually not being an injection of cash at all, but just a sort of redistribution. Because what's going to happen is local authorities potentially getting more money through this health and social care levy at some point in the future. But then actually the costs of the local authority providing even a static level of care are going to increase because of not just the sort of question of providers having to charge more, but all those other impacts that are going to be felt in the next few years as this comes into force.
And then one of the questions, I think, perhaps cross cuts for both of you, which is, if that is the case, that there's going to be this potential pressure on homes, it becomes important to think about this division that Arianna was talking about earlier, about what's going to fall inside what gets totted up and what falls outside. Because one of our questions said, well, would the answer from the home's perspective to effectively load those increased costs onto the hotel costs? I mean, do you think that that's a possibility, or is that going to be stamped on? What do you think?
I mean, given that we've been able to identify that as an issue at this early stage, what one would like to hope that there will be some regulations which deal with the question of what is and what's capable of being a hotel cost and what's a cost of care. It seems a really obvious potential flaw in achieving the stated aim if that isn't made clear, and if there is potential for ambiguity as to what's a care cost and what's a hotel cost.
Oh, Arianna, we can't hear you.
Oh, I'm so sorry. Sorry, is that coming through?
We can now.
Okay. There was a lot, in 2015, I think there was a lot of discussion around doing this as a flat rate. And I think that was very much from the view of local authorities not having to engage in this sort of discussion of trying to figure out precisely how much was the bed and the room and the heat and those sorts of things. Understandably, it's a very difficult calculation to make, but you do sort of wonder whether things will start to become top-ups that maybe aren't top-ups right now as well, of, do you want a room with a window? Do you want, and will those start to become things that are unnecessary to your care, in ways that other services sometimes are able to get slightly more money, but things that aren't strictly necessary, but now you probably wouldn't think twice about, having those as just your normal part of your provision in the care placement.
Yeah, it seems to me that, what you've got is a very sort of fragile system at the moment. And this has the potential to just increase the pressure on it. I mean, one of the things as well I thought was worth asking is, obviously what we know is that over the last few years, where providers have sought to challenge the rates that have been set, they haven't met really with any success on these sustainability questions. So I'm wondering whether, Sian, what flows from what you're saying is that there is more scope for sustainability challenges under this proposed regime.
I mean, I can really see those challenges coming through as a result of that sort of perfect storm of circumstances that I spoke about. And I think really from a local authority point of view, to sort of be in a position not to be vulnerable to those challenges, they're going to need to think very carefully about their market position statements and about how they sort of factor these events into the market in their areas in the future.
Yes, and I also wonder if there is scope for kind of some sort of joint challenge whereby, a sort of user organisation joins forces with a home and jointly to put pressure on a local authority, or equally whether a local authority will be pushing back and saying, we've only got X pounds, and then bringing in, the Secretary of State to justify. I don't know, can you see a sort of big litigation fiesta of that nature?
Well, potentially, it's, you know, I can see that the circumstances are there potentially to sort of give rise to that sort of challenge. It obviously the budget is the budget, but given that this is being billed as you know, a big injection of cash for local authorities, actually, if it's not working out in that way and local authorities are not receiving extra money because of all these factors, then they may well wish to lay that at the door of the DHSC.
Exactly. Now I'm going to sort of switch back to some of our earlier topics that were covered by Arianna. Because one of the questions that's been asked in terms of this sort of totting up to see whether you get to the cap or not is what's going to happen if people move from one area to the other. How, you know, are you going to have a sort of portable record, or is it going to be centralized? Does the command paper give us any insight into that?
It's less than the command paper. So that was actually factored into the CARE Act provisions on this, in terms of the CARE account being something that would have to be transferred over with you in the general provisions for moving from one local authority to another. And certainly it's not limited to costs incurred in any one local authority, and the CARE Act is quite clear that that should follow you wherever you go.
And then one of the other questions we've had is to sort of hear a bit more about this position of the sort of the young disabled person, or the person, you know, who's already disabled when they move into adult services. You know, what is all of this going to mean for them? And you know, can you flesh that out a bit more for us?
Yeah, and I should offer the sort of enormous health warning on this, that this is not part of the command paper. This was more from the Dilnot Commission and what was in Section 15 of the CARE Act, of specifically contemplating that something there would be essentially a different framework for younger adults with care needs. The Dilnot Commission, when it broke it down, had it in sort of two essential categories. And it didn't necessarily it wasn't entirely prescriptive as to how this would work, but they were pretty clear in terms of the overall view that for people who became 18 and immediately had eligible needs, and I noticed from one of the questions, they were noting that sometimes difficulties over getting diagnoses for younger people may be very tough for that. And I think that would potentially be a real issue to be looked at in terms of making a case that if that does become the cutoff point, that the person is eligible from the age of 18 onwards, and really establishing that in the run up to them turning 18. But the Dilnot Commission was actually somewhat more generous in its recommendation than that. It actually took the view that it should be anyone who developed care needs under the age of 40 should have a nil cap. The government in 2013 had the proposal that they were going to have the nil cap for people turning age 18. There is nothing in the command paper on it. The CARE Act framework retains the structure that allows this to happen, but there certainly has not been any formal announcement on this. And these were all coalition government announcements that were made around the nil cap, rather than anything more recent. But it's very much a part of the Dilnot recommendations. And to the extent to which this is just a project to implement the Dilnot recommendations, that very much was one of them. And I imagine should get more attention as these proposals are finalized.
Can I ask a question of Arianna and Fenella? Do you have the impression that there's an appetite to reform social care more widely than this command? Because this command paper, I think, takes quite a narrow approach, which is to deal really with the question of the cap and how it's going to be funded. But obviously we've touched on some of the issues, for example, the charging for domiciliary care, the charging regulations, and the sort of the outcome of the Norfolk case, and then there's the sort of the other question that Arianna's just talked about 18 those turning 18 with care needs. Do you think that there is that this is the start or the end in terms of reform?
I'll just start talking just because I'm not quite sure whether Fenella's connection
we may have temporarily lost Fenella.
A bit of difficulties there. I think. Oh, sorry, we've regained Fenella back online. I think in terms of the question of the overall appetite, I mean, I think one thing I would note is the command paper itself does offer a fairly clear message that while there would be an extra £5.4 billion funding for adult social care, it does explicitly state that demographic and unit cost pressures will be met through council tax social care precepts and long-term efficiencies. So I think in one way there is almost a limitation within the command paper of the idea of doing something about some of the existing funding challenges, and the money is more targeted at these new places. But Fenella may be much more able to answer on the broader question.
Yeah, I'm not sure that I got the whole of the beginning of the question. Is this the ICS question?
I think I was just asking whether this is the sort of the beginning of reforming social care, or is it all we're going to get?
I think this does tie in with one of the questions on the screen, which is about ICS's, integrated care systems, because what's curious is that we've got one strand of thought, which is all about integrating health and social care. And, you know, these projects to sort of meet the healthcare needs much more sort of holistically of the community. But on the other hand, all of this stuff about funding appears still to be a bit in a sort of social care silo. And it's not, as far as I can tell, there isn't any thought about how it's going to interact with CHC, and whether we're still going to be having, you know, those kind of turf warfare between health and social services about that. It also doesn't really seem, as far as I can see, to grapple with this concept of integration of healthcare. And what seems bizarre to me is it sort of calls health and social care, but there isn't a huge amount, as far as I can see, on the health side. It's still really looking at a sort of silo problem of residential care, you know, personal care at home, and so on. And I think it doesn't even seem to be in the 21st century with us in that sense. If you think about all the work that's being done on the health side, I don't know what you two think.
It just seems a missed opportunity to my mind, because there were some, you know, emergency measures last year in response to COVID for a more integrated approach to health and social care. And whether or not those were a success, it could have been used as a model for you know, a more integrated service, and it feels a bit like a missed opportunity to do something about the whole system rather than to perhaps I might say tinker around the edges, but that's very unkind.
Well, it just seems to have been looked at in a very sort of in a very limited way, and I agree, it is a missed opportunity, and it's got to be the beginning, but I don't know how you can begin something without looking at the whole thing. I think that's the principal difficulty.
Particularly with a finite budget.
Have you got any other questions that you've seen that you'd like to pick up on? Or Sian, either of you?
I have to say, I hadn't been keeping an eye on.
Well, that's fine. Well, I mean, I was keen that I should allow everyone to, you know, be able to go and do bath time with their kids, or have a glass of wine, or whatever it is that is going to fill your evening. And I just wanted to say, you know, thank you very, very much for all these fantastic questions, which show, you know, how much there is to think about. For those of you who have felt that they've had a bit of a sort of tsunami of information, as well as a paper being sent out, this session's been filmed and it'll be on our website, I think tomorrow, as will the slides be. So again, if you want to sort of re-immerse yourself in the complexities, you'll be able to do so with a number of media. And also, as I've said, once the sort of wider team at 39, with all its range of experiences, had a chance to think more and perhaps see some of the other responses to the documents, we'll be doing a kind of a longer and more considered version of this. Perhaps we'll have all the answers by then. But in the meantime, thank you very much to the speakers. Thank you very much for participating, and I hope you have a good evening.
Thank you all.